what is the clinical routine at your place now? And I was thinking first of medical treatment, and who would go for nothing? Up with their hand.
I wonder if I could perhaps focus the question from the neurological perspective. So the first question is, do you restart anticoagulants? I guess as a very focused question.
Okay, because that would imply that question because of
and then the
none.
second question might be, do you do it under a month or later than a month?
Okay.
Who restarts anticoagulants on patients with AFib and a history of ICH? So that's a bunch. And who does not? Who sees it as an absolute contraindication? Interesting. So most people are comfortable restarting it. And just out of curiosity, the timing.
Yes, and of course this PENLET study is quite recently published and so on. But how would you have? And of course it could be many issues here and the etiology of the bleeding and so forth and so forth. But if we take this patient that this 80-year-old woman that Eivind presented, non-complicated ICH. And when to restart, and would you wait? Help me here. Would you wait?
I proposed a month.
Yeah.
How about a month? Is a month too long? No, a month is not too long. How about a week or two? Would anybody restart after a week or two? Yes. That's interesting. I mean, just personally, with very few data to guide us, of course, if it's an uncomplicated small basal ganglia hypertensive hemorrhage in someone with AFib, I wouldn't mind restarting after a couple of weeks with a head CT to suggest that it's not worsening.
Hans Christoph, would you have a comment on this? Would you super early?
It's extremely frustrating because we developed a protocol which has a factorial design. So one arm is anticoagulation versus aspirin or nothing. The other arm is randomization after 3 or 6 weeks. We submitted it to all the NOACs companies. They all refused. Then we submitted it to the German Research Council, and they said she should be paid by the pharmaceutical companies. We won't spend money on this as long as the drugs are protected. So that's a dilemma, and we cannot do the trial without adequate money. But I think that's the way to approach it, is a factorial design.
And in your proposal, was it any specific anticoagulant that you decided on there, or?
No, we basically said a NOAC,
Yeah.
and ideally we would have wanted to get money from all 4 companies, so it would be the choice of the physician which NOACs he takes. I don't care, because I don't think there are major differences in this respect, and then against either nothing or an antiplatelet drug.
Okay, that for clinical trials, and so the majority would restart on an anticoagulant, but I don't think that we sorted this out, because of a few would start after 1 month. But should we wait 3 months in the typical 3 months after reinitiating or initiating oral anticoagulants after this patient with ICH and atrial fibrillation? 3 months? Hands up. It depends. Yeah.
As a cardiologist, I'm finding this conversation quite difficult, because it would make perfect sense to me if we didn't have left atrial appendage occlusion as an option, but we do. So for me, the only trial that makes any sense at all is the French trial, and I'm really surprised to see studies of intracranial hemorrhage being restarted on anticoagulants. I mean, you can imagine the conversation with the patient. So, you know that medicine we gave you? Yes, doctor, I know. You're the one that gave you a brain hemorrhage, yeah, and you nearly died. Yeah, well, we're going to start it again. I mean...
Yeah, can I comment on this?
Of course.
90% of all intracerebral bleeds in the world happen in people who have no access to interventional therapy. And we first have to answer the question for China and India and countries like this. I'm totally with you if we talk about the US and Europe, highly sophisticated medical systems. But I think we urgently need information for all the countries where this is not available.
Would you agree? Refer to Europe?
I think it's a really good point. I mean, I'm not entirely sure that China and India are actually the right examples that don't have access to these kind of therapies and don't have them coming. But I accept your point on a sort of global perspective.
And of course, I'm quite much in pro of a plug implantation, if that, and we will try to do this in the stroke close randomized controlled trial now. But even in at least Sweden, we don't have implanters at all. It's at all the university centers, and since this is rather new, intervention. So we don't have the infrastructure to take care of the patients. So that it is a reasonable question at this moment here now. Classification of patients. Yes, because of course we should have clinical knowledge, and if you should see stroke patients, you should know your stroke lesson, and you would have to. But is it a special thing? Other scales you would propose, or just that you would have competent people on board adjudicating events? What would you say?
Well, the latter, certainly. I hope they're competent people on board. No, I mean, my point was about, it came up with the PFO trial, with the RESPECT trial and with the others, which is that stroke is not a disease. And when we subcategorized and looked at the outcomes which could plausibly be associated with PFO closure or not PFO closure, the effect size was much stronger when you removed the ones that had nothing to do with the treatment that we were investigating. And I think there may be an analogy with the LAA occluding therapies, because there will be strokes in these elderly patients with atrial fibrillation that will have nothing to do with cardioembolism. It can be hard sometimes to be absolute about the etiology, but we can sort of probabilistically get to it. And the ASCOD classification is fairly standardized and operationalized, so it's not too hard to say probabilistically that this was this kind of disease and that was that kind of disease. And if you do it conservatively, like we did with RESPECT, we said if they have a grade 1 cause, let's say that's not potentially PFO related. There were other patients that had subtler potential explanations, but we kept them in the still cryptogenic category. I think that kind of analysis might be useful. And part of the trouble that we had in convincing people of this approach was that we came up with it later. And so it was clearly post hoc, and we made the point that it was post hoc. We were open about it. But if we anticipate that there are going to be outcomes which are going to cloud the interpretation of a device trial for a specific stroke mechanism, then you can at least have a secondary outcome or something of strokes of known cause, non-cardioembolic, might be excluded and interpreted separately.
Yeah, because I was thinking from a clinical point of view. Of course, from a pathophysiological point of view, it's of quite much interest if you would put in a plug-in that would prevent from cardioembolic events. But then from a clinical point of view, the patient had a dissection, yes, sorry, it was perfect result in this trial, but you had the stroke anyway. So it has to be a secondary analysis, right? Because of otherwise it will just be focused on specific subtypes of strokes, and then it will be.
But you see, that makes perfect sense to me. I mean, like my mastectomy example, it doesn't make any sense to anybody in this room to have all cancer emerging after mastectomy be the outcome for a mastectomy trial. That wouldn't make any sense. And similarly, though it's not as discriminable, perhaps, the outcome events as being breast cancer or something else, I think we should at least entertain the possibility of including that in our analysis.
To include that, but perhaps not be a primary endpoint.
It would be hard, I think, to convince many people because of the probabilistic nature of the outcome.
Question?
I think there's a lot of factors so that the type of the hemorrhage, the localization of the hemorrhage. But my question is, do you choose or do you change the anticoagulant after the hemorrhage? For example, someone has hemorrhage on warfarin, so you stopped it. Do you think to change for NAUCO after?
Oh, definitely, because the risk of intracerebral hemorrhage is reduced by 40 to 80% with the NOAC compared to warfarin. So I think anyone who has a bleed on warfarin should be switched. We have no idea what we should do if someone has a bleed on NOAC and there was no interaction with kidney function or something else. This is totally unknown.
So one of the grandfathers of stroke neurology, C. Miller Fisher, who just died a couple years ago, once said that if you have a single patient on warfarin, you should wake up at least once a night in a cold sweat. I don't know if that applies to NOACs. I feel much more comfortable on patients on NOACs.
Okay, something more to comment from you, Hans-Christoph?
I think we have, in 5 minutes, we have to move to the interesting debate between a cardiologist and a neurologist.
Okay, then I would like to thank you all for coming to this interesting session. Thank you. It's closed.